Good morning, everyone. Welcome to Grand Rounds. I'm Dr. Fernandez, and today we're dividing into a topic that I generally believe is one of the most underappreciated and clinical consequential areas in echocardiography, diastolic dysfunction. Let me start with a provocative question. How many of you have ever reported a normal echo on a patient who came back 6 months later in heart failure with preserved ejection fraction? If you're being honest, most of you are nodding right now. That gap between what we measure and what the patient experiences is exactly what today's talk is about. We're going to cover the 2025 AACVI Guidelines, which represent a major leap forward. We'll go through physiology, the algorithm, the special population, exercise, stress echo, and heart failure with Preserved EF diagnosis, all with clinical cases woven throughout. Buckle up. This is going to be clinical rich, around 60-minute talk. Learning objectives. Here are our 6 learning objectives for today. I want to call your attention to object number 4, a special population. This is where, in my experience, we make the most errors in clinical practice. The standard algorithm simply doesn't apply in atrial fibrillation, hypertrophic cardiomyopathy, or mitral annular calcification, and yet most of us apply it anyway. By the end of today, you'll have a mental algorithm that you can apply at the echo machine in real time. You won't need to look anything up. Let's get to it. Disclosure. Always a great slide to have for exactly 2 seconds. Moving on. What is diastole? Definition and conceptual framework. Here's where I want to challenge a fundamental assumption. Most of us were taught that diastole is the rest phase of the cardiac cycle. The heart relaxes, blood flow impassively, easy. That's wrong, and understanding why is wrong is the foundation of everything we'll talk about today. Diastole is an active, energy-consuming process. The early phase of relaxation, isovolumic relaxation, is powered by ATP. The circa 2A pump has to actively suck calcium back into the sarcoplasmic reticulum for the myofilaments to let go. This is where diastolic dysfunction is first thing to go in myocardial ischemia, before systolic dysfunction appears, before the EF drops, before the troponins rises. The heart ability to relax is already impaired. Think of it this way. If systole is the hand squeezing a sponge, diastole is the hand opening back up and allowing the sponge to re-expand and absorb. If the opening mechanism is broken, if the hand is stiff or weak, the sponge never fills properly. Your cardiac output suffers even with perfect normal squeeze. The 4 definitions on this slide, temporal, functional, hemodynamic, and clinical, give us 4 lenses on the same phenomenon. The 4 phases of diastole, a physiological premiere. Now, let's break diastole into its 4 sequential phases. Each phase has distinct physiological mechanism, a distinct echo correlate, and a distinct clinical meaning when it goes wrong. Phase 1, isovolumic relaxation, IVRT. Both valves are closed. LV pressure is falling from systolic peak. This is the most energy-intensive moment, duration 60 to 100 milliseconds normally. In echo, IVRT greater than 100 milliseconds is equivalent to grade 1 dysfunction. Think of it as the spring recoiling before it can pull anything in. Phase 2, rapid early filling, or E-wave. The mitral valve opens because LV pressure drops below left atrial pressure. Blood rushes down a pressure gradient. This is passive, driven by the suction created during the IVRT or phase 1. This produces the E-wave on mitral Doppler, normally the dominant filling phase. Phase 3, diastasis. LA and LV pressures equalize, minimal flow. This phase disappears entirely at heart rate above 80 beats per minute. When the stasis is gone, total filling time is critically reduced, one of the core mechanisms of exercise intolerance in heart failure with preserved EF. Phase 4, atrial contraction or A wave. Active atrial kick provide the final 20 to 30% of LV filling, critical in stiff ventricle. Loss in atrial fibrillation, which is why atrial fibrillation is so poorly tolerated in patients with significant diastolic dysfunction. Invasive pressure tracing, hemodynamic reference. This slide shows the pressure tracing from cardiac catheterization, the gold standard against which all our echo parameters are validated. Look at the left panel, the LV diastolic pressure tracing. Notice the LV pressure has a minimum point, then a rapid filling wave, or RFW, then rises again with atrial contraction, the A wave, and then reaches the end diastolic pressure. This entire trajectory is what we're trying to reconstruct non-invasively with echocardiography. The right panel shows simultaneous LV and LA pressure, the transmitral gradient, the difference between the LA pressure and the LV pressure during early filling is what drives the E wave velocity. When left atrial pressure is elevated, the E wave gets bigger and faster. This is the conceptual foundations of E to E prime as a filling pressure surrogate. Molecular physiology of myocardial relaxation. Now let's go one level deeper to the cellular and molecular level. I promise this has direct clinical relevance. The 5-step cycle shows here tells us why diastolic dysfunction occur in so many conditions. Step 1, calcium floods the cytosol during systole. The machine contracts. Step 2, relaxation begins when CAMP and PKA signals activates, phosphorylating phospholambda and unleashing SERCA2A. Step 3, SERCA2A pump 70% of calcium back into the sarcoplasmic reticulum. This is ATP dependent energy required. The NCX exchanger handles the remaining 30%. Step 4, as calcium falls, troponin C releases its grip, titin, the giant elastic protein that acts like a molecular spring, stores energy during systole and releases it during early diastole, contributes to the elastic recoil that helps fill the ventricle. Step 5, LV pressure falls during IVRT, creating the pressure gradient that opens the mitral valve and generates the E wave. Clinical implication of this pathway: ischemia leads to ATP depletion, which leads to SERCA2A fails. Calcium remains elevated, which leads to myofilaments can relax. Diastolic dysfunction appears before any systolic dysfunction. Hypertrophic cardiomyopathy leads to altered titin isoform, which leads to increased passive stiffness and which leads to impaired early relaxation. Beta blockers medication reduce PKA activity, which leads to slower SERCA2 activation, therefore potential mild worsening of diastolic relaxation rate, though net benefit in heart failure with reduced EF is clear. Determinants of diastolic function. What regulates filling? 6 independent determinants. Any of them can be dominant culprit in a given patient. Let's walk through them quickly because recognizing which determinant is pathologically impaired determines both prognosis and management. Myocardial relaxation rate, governed by SERCA2A activity and myofilament calcium sensitivity, slowed by ischemia, LVH, aging, hypothyroidism. Echo correlate, prolonged IVRT, and reduced E prime velocity. This is the classic impaired relaxation mechanism or grade 1 dysfunction. Number 2, LV elastic recoil. The ventricle stores elastic energy during systole and releases in early diastole, creating a suction that assists filling. Dependent on titin, reduced in dilated cardiomyopathy. This is partly why patients with dilated cardiomyopathy and low EF often have paradoxical better looking E to A ratios early in disease. Number 3, LV passive compliance or chamber stiffness. This is the dominant mechanism in advanced heart failure with preserved EF. Myocardial fibrosis, collagen cross-linking, concentric geometry, all increases passive stiffness. A stiff ventricle needs higher filling pressure to achieve the same end diastolic volume. LVEDP goes up and eventually means left atrial pressure goes up as well. Number 4, left atrial function. The LA is not just a passive reservoir, it's a booster pump and an early warning system. Left atrial reservoir strain, LARS, reflects the integrated health of this function. In the 2025 guidelines, LARS less than 18% is now a key adjudicating parameter for elevated left atrial pressure. Number 5, pericardial constraint, relevant in constricted pericarditis and large effusions. External compression limits diastolic filling independently of myocardial disease. We'll come back to this when we discuss differentiation from restricted cardiomyopathy. Heart rate and diastolic filling time. That's number 6. As heart rate rises, diastole shortens with more than systole. Above 80 to 100 beats per minute, diastasis disappears and filling time is critical shortened. This is plain exercise intolerance in heart failure with preserved EF, the very thing that increased demand. Exercise, fever, anemia also shorten the time available to meet it. Historical evolution of diastolic dysfunction assessment. Let me take you on a 60-year tour of how we got here, because context matter and because understanding why each generation of guidelines improve on the last help you understand what to actually trust today. In the 1960s, Grossman and Wiggers defined diastolic dysfunction with invasive catheter. It was the gold standard then, and the gold standard still. In 1980s, pulse-wave Doppler gave us the mitral inflow E to A ratio, revolutionary but badly load-dependent. Volume, load a patient and they look pseudo-normal, dehydrate them and grade 2 looks like a grade 1. In 1997, Nguyen introduced tissue Doppler and the E prime velocity. This is the breakthrough. The myocardial annulus move independently of loading condition, and the E to E prime as a filling pressure surrogate transformed the field. 2009, first formal EACVI Guideline standardized the approach. 3-grade system, E to A, E prime, E to E prime, LAVI, TR velocity. In 2016, updated guidelines from the Nagu et al. Simplified to 4 parameters, introduced the indeterminate category, better, but still too many patients falling into the indeterminate bucket. 2019 to 2024, the LA strain era, multiple studies, Sine, Lancelotti, Smithson, showed that the LARS less than 18% predicts elevated filling pressure better than the E to E prime alone in indeterminate cases. This evidence base for the 2025 guidelines. In 2025, Smithson's on an unified algorithm with LARS as the key adjudicator, dedicated atrial fibrillation pathway, age-specific reference range, heart failure with preserved EF probability linked directly to echo grade. This is where we are today. Now, clinical importance of diastolic dysfunction, why it matters. Numbers on this slide deserve to be emphasized because they reframe what diastolic dysfunction means clinically. Over 50% of all heart failure hospitalization, the most common cause of hospital admission in adults over 65, are heart failure with preserved EF, which is fundamental a diastolic disorder. 83 million Americans have hypertension, the single greatest risk factor for diastolic dysfunction. We're not talking about a rare finding. We're talking about something that affects the majority of our patients. Grade 2 diastolic dysfunction carries a 3 to 8 times higher mortality hazard compared to normal echo findings. For perspective, that rivals many malignancies. 34% 5-year mortality for symptomatic diastolic heart failure, comparable to many stage 3 cancers. And perhaps the most important message for this room, diastolic dysfunction precedes systolic dysfunction. In hypertension, diabetes, metabolic syndrome, the diastolic abnormality appears years before the ejection fraction declines. This gives us a detection window. If we identify and grade it correctly, we have an opportunity to intervene before overt heart failure develops. In the 2025 guidelines now directly link echocardiography grade to management. Grade 2 triggers SGLT inhibitors and diuresis optimization. Grade affects prognosis in heart failure with reduced EF. Restrictive physiology predicts needs for advanced therapy. This isn't academic. It changes what you do when you see patients. 2025 AACVI Guidelines update. We are now entering the core of today's lecture. The 2025 Guidelines, everything we've covered in physiology was built to this. Let's walk through the major updates, then go step by step through the algorithm. Background and rationale for the update. Why update a perfectly good 2026 algorithm? Because it wasn't perfectly good. It had 3 major limitations. First, too many indeterminate cases, up to 30% in some series. An algorithm that throws out its hand 1/3 of the time isn't clinically useful. Second, it had no dedicated pathway for atrial fibrillation, which affect precisely the population most likely to have diastolic dysfunction. Third, the age-specific reference range were inadequate. A lateral E prime was 7 centimeters per second in a 30-year-old is mildly reduced. The same value in a 72-year-old is completely normal. The 2016 guidelines were treating everyone the same. The 5 key updates in the 2025 guidelines: LA reservoir strain added as a core supplement parameter, cut off less or equal to 18%, age-specific reference range by decade for all major parameters, a simplified algorithm with clear decision tree and fewer indeterminate outcomes, LV global longitudinal strain integrated for heart failure, Preserved EF diagnosis and subclinical dysfunction, exercise echo criteria, refined E to E prime greater than 14 and TR greater than 3.2 required for positive diagnosis of heart failure with Preserved EF. Invasive hemodynamics foundation. Before we use echo parameters clinically, we need to understand what we are actually trying to measure, and what we're trying to measure is what a cardiologist will see if they stuck a catheter into the left heart. The key distinction in this table, LVEDP versus mean left atrial pressure, is one of the most important and most overlooked points in diastology. LVEDP may be elevated while mean left atrial pressure is still normal. This is grade 1, early preclinical diastolic dysfunction. The atrium hasn't failed yet, only the ventricle is showing signs of stiffness. Once mean left atrial pressure becomes elevated, LVEDP is always elevated too. This is grade 2 or 3. This distinction matters because different echo parameters correlate with different invasive measurements. A velocity, AR minus A duration, and the LA pump strain correlates with LVEDP. E velocity, E to A ratio, E to E prime, and LARS correlate with mean left atrial pressure. So when we use E to E prime to estimate feeding pressure, we are really estimating mean left atrial pressure, the more clinical relevant parameter for symptoms and hospitalization risk. If asked what echo parameters best estimate LVEDP specifically, the answer is AR duration greater than 30 milliseconds, not E to E, not LARS or AR minus A. Parameters required for Transthoracic echo assessment. Introduction. The next several slides walk through the echocardiography parameters using the 2025 algorithm. Rather than reading through them passively, think of this as a toolkit review. Each parameter has a why we measure it and how we measure it, and when to trust and when not to. Transmitral inflow, E and A wave. The mitral inflow Doppler is our oldest and most familiar diastolic tool. Pulse wave Doppler at the mitral valve tips gives us the E wave early filling and the A wave atrial contraction. When to measure: E velocity, peak early filling velocity; A velocity, the peak atrial contraction velocity; E to A ratio, the single most recognizable diastolic parameter; E deceleration time from E peak to baseline. Short deceleration time less than 100 milliseconds is equivalent to restrictive physiology. Limitations, the clinical ones: E to A is exquisitely load dependent. Pseudo-normalization occurs when impaired relaxation. Grade 1. E to A less than 8 is masked by elevated left atrial pressure. The E wave is pushed up by high left atrial pressure, making E to A look normal, 0.8 to 2, even though filling pressures are elevated. E to A can be used alone, is always interpreted in context of E velocity prime and other parameters. Mnemonics: E to A lies, E prime doesn't. Tissue Dopplers: E prime velocity is load independent. When E to A looks at the normal, E prime will still be reduced and E to E prime will be elevated. That's the diagnostic key. TDI at the mitral annulus, E prime and E to E prime ratio. Tissue Doppler imaging at the mitral annulus is the cornerstone of the 2025 algorithm as it was in 2016. The E prime velocity measures how fast the myocardium itself is moving during early diastole. Is independent of loading condition. Measures septal E prime at the septal mitral annulus in the apical four chambers. Lateral E prime at the lateral mitral annulus. Average E prime, septal E prime plus lateral E prime divided by 2. Key cutoff in 2025. Reduce E prime, septal less or equal to 6 centimeters per second, or lateral less than 7, or average less than 6.5. E to E prime greater than 14, average elevated left atrial pressure. E to E prime less than 8, normal left atrial pressure. Pitfall: mitral annulus calcifications. Artifactually reduced E prime. Do not use E prime or E to E prime in severe mitral annulus calcification (MAC). Pulmonary hypertension with septal flattening, use the lateral E prime only, not average. Post-cardiac surgery, annular motion may be altered, use with caution. Pro tips: always measure both septal and lateral E prime and report average. Isolated septal or lateral readings can be misleading. The 2025 Guidelines endorses average E prime as the primary measurement. Left atrial volume index, LAVI. LAVI is our marker of chronicity. An enlarged left atrium tells us the ventricle has been stiff and demanding for a long time. The atrium has been stretched repeatedly, remodeled, and is now permanently enlarged. Measurement by plain Simpson method in end systole just before mitral valve opens. Index to body surface area. Normal is less or equal to 34 milliliters by meter square. Exclusion: do not use LAVI as a diastolic marker in athletes which have physiological LA enlargement from volume loading, moderate to severe mitral regurgitation, volume overload, enlarged left atrial independently, mitral stenosis, LA enlarges from mechanical obstruction, atrial fibrillation. AFib itself causes left atrial enlargement. In this condition, LAVI is unreliable as a filling pressure marker and should be excluded from the step 2 algorithm. Clinical pairs: LAVI greater than 34 in a patient without this exclusion is a red flag. It means they had elevated feeling pressure long enough for a structural remodel. Even if today's echo parameters are borderline, the LA remembers the chronically elevated pressure. Peak TR velocity and peak arteriosystolic pressure, pulmonic arteriosystolic pressure. The tricuspid regurgitant jet velocity gives us pulmonary artery systolic pressure. An elevated PASP is one of the three primary variables in left atrial estimation algorithm. Why does elevated pulmonic arteriosystolic pressure indicate elevated left atrial pressure? Because post-capillary group 2 pulmonary hypertension is driven by elevated left heart filling pressures. When LA is chronically elevated, pulmonary venous pressure rises, pulmonary artery pressure rises reactively, and the TR jet accelerates. TR velocity is greater or equal to 2.8 meters per second, which is equivalent to pulmonic arteriosystolic pressure more than or equal to 35. Signal this upstream pressure transmission. Technical tips. You need to optimize the TR signal with agitated saline if TR envelope is incomplete. Measure at least 5 beats, 10 in atrial fibrillation, and take the mean. In primary pulmonary hypertension, group 1 pulmonary hypertension, TR is elevated without elevated left atrial pressure. So TR alone doesn't diagnose post-capillary pulmonary hypertension. You need the context. Clinical distinction. In group 1 pulmonary hypertension, E prime is often preserved, normal relaxation. E2 E prime may be low normal, and LARX is relatively preserved. In group 2 pulmonary hypertension, elevated left atrial pressure, E prime is reduced, E2 E prime is elevated, and LARS is reduced. This is the echo differential for pulmonary hypertension classification. Pulmonary vein inflow. Pulmonary venous Doppler gives us the systolic to diastolic ratio, forward flow velocity, and the pulmonary vein A reversal velocity wave. S systolic to diastolic ratio. Normally, systolic is greater than diastolic. More forward flow in systole than diastole. When left atrial pressure is elevated, systolic forward flow is blunted. The high left heart pressure pushes back against the pulmonic venous return in systole, which leads to a systolic to diastolic less than 1, or a pulmonary vein systolic filling fraction less than 40%, which is equivalent to elevated left atrial pressure. AR minus A duration. The pulmonary vein A reversal, AR, occurs just before the mitral A wave. AR minus A greater than 30 milliseconds is equivalent to elevated LVDP. The high-end diastolic pressure causes a proportionally longer reversal. This is one of the most reliable markers of elevated LVDP specifically, and remains valuable in hypertrophic cardiomyopathy and other special population. Limitations. Technically challenging. Requires good posterior window and correct sample volume placement. S wave is unreliable in moderate to severe MR. S is reduced by regurgitation, not by left atrial pressure. Practical tip. The pulmonic vein is often overlooked in routine echo. Make it part of your standard protocol. It takes 30 seconds and can resolve an indeterminate case. IVRT, or isovolumic relaxation time. IVRT is the interval from the aortic valve closure to mitral valve opening. The energy-intensive unplugging phase of diastole. Clinical interpretation. Prolonged IVRT greater than 100 milliseconds is impaired relaxation. The ventricle is slow to release. Classic grade 1 pattern. Normal IVRT 70 to 100 milliseconds. Normal relaxation. Short IVRT less than 70 milliseconds. Elevated left atrial pressure. The mitral valve opens early because left atrial pressure is so high it overcomes LV pressure quickly. Grade 2 to 3 pattern. IVRT is particularly valuable in two special population contexts: mitral annular calcification, where E is prime is unreliable, and sinus tachycardia, where E to A fusion make the mitral inflow uninterpretable. Quick clinical scenario: patient with severe MAC tachycardia at 105 beats per minute, fuse E to A on a mitral Doppler, E prime artificially low. You can use E to E prime or mitral inflow, but IVRT less than 70 milliseconds gives you 79 specificity for elevated left atrial pressure. That's your answer. LV global longitudinal strain. GLS is a 2025 addition to the Diastolic Function Toolkit, primarily for subclinical dysfunction detection and heart failure with preserved EF diagnosis. Normal LV GLS is approximate minus 20%. Values of greater than minus 16% less negative indicates a subclinical systolic dysfunction. Important because patients with heart failure with preserved EF often have mildly reduced GLS even with preserved EF. GLS detects this before EF drops. Two specific uses in the 2025 guidelines. Subclinical dysfunction marker. GLS greater than minus 16 in patients with preserved EF and diastolic parameters suggest early stage B heart failure even without symptoms. Cardiac amyloidosis. The apical sparing pattern where the apical GLS is preserved but basal GLS is severely impaired is a hallmark of cardiac amyloidosis. Combined with a 5-5 sign, septum greater than 12 millimeters, EF greater than 50, E to E prime greater than 15, GLS pattern is highly specific for amyloid. Teaching peril. When you see a patient with a normal EF of 55, grade 2 diastolic dysfunction, GLS of less than 14, and a basal strain worse than an apical, think amyloidosis. Order PYP scan. This pattern should never be casually labeled as hypertensive heart disease. Combined parameters overview slide. The slide gives visual summary of how all parameters fit together. Primary versus supplementary. The color M mode. Propagation velocity. The color M mode propagation velocity measures how fast blood propagates from the mitral valve into the LV apex during early filling. Clinical use. BP less than 45 centimeters per second is impaired relaxation, and E to BP greater than 2.5 correlates with elevated left atrial pressure and has been validated as a supplemental parameter. BP is relative load independent, which is an advantage. However, it's technically demanding, requires careful M mode placement, and is less widely validated than LARS. In the 2025 algorithm is a second-tier supplement parameter used when more reliable parameters are available or technically inadequate. TE to E prime time interval. The TE prime interval is the time from the peak of the E wave on mitral inflow Doppler to the peak of the E prime velocity on tissue Doppler measured simultaneously. Normally, E prime peaks slightly before E. The myocardium relaxes first, creating a suction that draws blood in. When relaxation is severely impaired and left atrial pressure is elevated, E prime peaks after E. The sequence reverses. Clinical cutoff. TE minus E prime less than 0 milliseconds. E before E is normal. TE minus E prime greater than 0 milliseconds, especially greater than 22, elevated left atrial pressure. TE to E prime IVRT less than 5.6, elevated left atrial pressure, validated particularly in mitral stenosis. This parameter is technically demanding and not part of most routine echo protocols, but is valuable in mitral stenosis where E velocity is confounded by the stenosis itself. Filed under Special Population Toolkit. And now the peak T PR and Diastolic velocity. The pulmonary regurgitation and diastolic velocity allows estimation of pulmonary arterial diastolic pressure. Applying the modified Bernoulli equation, pulmonary arterial diastolic pressure is equal to 4 times PR velocity squared plus estimated right atrial pressure. A P artery diastolic pressure greater than 16 millimeters suggests elevated left atrial pressure in the absence of precapillary pulmonary hypertension. This is particularly useful when TR velocity is inadequate for pulmonary arterial systolic pressure estimation, but the patient does have a measurable PR yet, providing an alternative window into pulmonic pressures. Clinical note: PR is present in especially all patients with any degree of pulmonic regurgitation on color Doppler. Make it a habit to attempt PR velocity measurements when TR is suboptimal. Left atrial strain. The 2025 star parameter. If there is one new concept from the 2025 guidelines to take home today, this is it. Left atrial reservoir strain. The left atrial has 3 functional phases: reservoir, filling during LV systole, conduit, passive blood transfer in early diastole, and booster pump atrial contraction. Left atrial reservoir strain, LARS, specifically the reservoir strain, reflects the integrated compliance and function of the left atrium. When LV filling pressures are chronically elevated, the LA chronically stretch. Like any muscle, under chronic stress, it remodels, it becomes less compliant, its strain decreases, its reserve function deteriorates. LARS less than 18% is the threshold for elevated left atrial pressure in the 2025 guidelines. Why is LARS, LA reservoir strain, superior to E to E prime for adjudication? Less load dependent than mitral inflow parameters, reflects chronically feeling pressure burden, not just the moment of measurement. Validated against invasive hemodynamics in multiple large studies, particularly powerful in indeterminate cases where E to E prime is in gray zone, 8 to 14. The formula on the slide, LARS is equal to minus LASCD plus LASCT, where CD is conduit and CT is contractility. Most modern echo software calculates this automatically from the speckle tracking algorithm. Core parameters, the 3 primary variables. Now let's crystallize the 3 primary variables that anchor the left atrial pressure estimation algorithm. These 3 parameters, E prime, E to E prime, and TR, pulmonary arterial systolic pressure, are the first line decision makers. Parameter 1, mitral annual E prime velocity, is a marker of LV relaxation. Septal less than 6, lateral less than 7, or average less than 6.5 means it's reduced. It's a load independent, reduced across all grades of diastolic dysfunction. Is the gateway to the algorithm. Parameter 2, average E to E prime ratio, estimated of left atrial pressure. E to E prime less than 8 is equal to normal left atrial pressure, 8 to 14 indeterminate, and greater than 14 elevated left atrial pressure. Combine preload E wave and relaxation E prime, the best non-invasive surrogate for mean left atrial pressure. Parameters 3, TR velocity or pulmonary arterial systolic pressure, reflects elevated left atrial pressure. TR greater than 2.8 or pulmonary arterial systolic pressure greater than 35 is equal to elevated. Use agitated saline if TR signal is incomplete. Estimate right atrial pressure for accurate PSP. Not reliable if primary pulmonary hypertension group 1 is present. This is a key teaching point. The 3 parameters were chosen because they assess 3 different aspects of the feeling pressure problem: myocardial relaxation, transmitral driving pressure, and downstream pulmonary vascular response. Together, they're more powerful than any single parameter. Age-specific reference range, one of the most important practicals update of the 2025 guidelines. Everything is now age stratified. Let me walk you through why this matters with a concrete example. Take a septal E velocity, normal range, in a 25-year-old, 7.2 to 16.4. Normal range in a 70-year-old, 4.1 to 10.6. If you apply the 2016 cutoff of less than 7 centimeters uniformly, you'll diagnose diastolic dysfunction in most healthy elderly patients. If you apply age-specific ranges, you'll be much more accurate. A few key observations from the table. E to E ratio falls dramatically with age, from 0.5 to 2.7 in young adults to 0.5 to 1.4 in over 60. An E to A ratio of 0.7 in a 65-year-old is completely normal. The same value in a 35-year-old warrants investigation. When you are reading an echo on a 72-year-old with septal E prime of 5 and an E to E prime of 13, don't reflexively call grade 2 diastolic dysfunction. Check the age-specific ranges to get a full picture. Diagnosis diastolic dysfunction, the two-step approach. Here's the diagnostic algorithm for determining whether diastolic dysfunction is present. This is step 1 and step 2 before we worry about grading. Assess E prime as a marker of impaired relaxation. A septal less than 6, lateral less than 7, or average less than 6.5 are normal. And use a specific cutoff for more precision. Assess marker. Step 2. Assess markers of left atrial and LV remodeling and elevated left atrial pressure. An average E to E prime greater than 14, LARS less than or 18%, E to A ratio less than 0.8 or greater than 2, LAVI greater than 34, with exclusion applied, LV max index elevated. Decision rule: E prime reduce and greater than 1 marker in step 2 present is diastolic dysfunction is present. E prime preserved but greater than 2 markers in step 2 are present. Diastolic dysfunction is present. Neither condition met, normal diastolic function. This two-step approach is more sensitive than the 2016 guidelines because it allows diagnosis even when E prime is preserved, which can happen in early infiltrate disease or in a specific pattern of LV hypertrophy. Left atrial pressure estimation algorithm and overview. Once we establish that diastolic dysfunction is present, we estimate left atrial pressure using 3 primary variables: E prime, E to E prime, and TRPSP. The decision 3. All 3 are normal. Left atrial pressure is elevated, graded by E to A less than 2 leads to grade 2. E to A greater than 2 is grade 3. All 3 normal. Left atrial pressure is normal. 1 or 2 are normal indeterminate. Assess supplemental parameter. A special case: if only E prime is reduced and E to A is greater than 0.8, you cannot call grade 1 based on E prime alone. You must check supplemental parameters. If supplemental parameters are all normal, left atrial pressure is normal, and you diagnose grade 1 diastolic dysfunction, impaired relaxation with normal left atrial pressure. This catches the critical clinical scenario where impaired relaxation and elevated left atrial pressure are coexistent, which is exactly the pseudo-normal pattern that caused so much confusion in the 2016 era. Algorithm tip: jot this decision tree on a whiteboard while talking through it. The visual anchoring helps trainees internalize the logic. 3 branches: all bad, all good, and mixed. Supplemental parameters for indeterminate cases. When 1 or 2 of the 3 primary variables are abnormal, we turn to supplemental parameters to adjudicate. Think of this as tiebreakers. The supplemental parameters hierarchy in 2025. LARS less than 18. Best validated, most powerful. If available, use first. Pulmonic vein systolic to diastolic ratio less than 0.67. Systolic filling fraction less than 40. A strong alternative requires good pulmonic vein signal. LAVI greater than 34 chronic marker. Apply exclusion rigorously. IVRT less than 70. Useful when other parameters unavailable. PR and diastolic velocity greater than 2. Or pulmonic arterial diastolic pressure greater than 16. Alternative when TR is inadequate. Mitral L wave greater than 50 centimeters per second. Mid diastolic flow indicating delayed relaxation plus elevated left atrial pressure. AR minus A, duration greater than 30 milliseconds. LVDP specific marker. Used in hypertrophic cardiomyopathy and MR. Valsalva, greater than 50% drop in E2A, distinguish pseudonormal from true normal. Interpretation rule: if supplemental parameters are abnormal, left atrial pressure is elevated, and then you can grade by E to A ratio. If supplemental parameters are normal, left atrial pressure is normal. Practical tip: in most clinical labs, LARS is the go-to supplemental parameter. If your lab doesn't measure it routinely, now is the time to implement it. Pulmonary vein systolic to diastolic is your backup. Between the two, you'll resolve the vast majority of indeterminate cases. 2025 algorithm visual full diagram shown in the guidelines. This is a full visual representation of the 2025 left atrial estimation algorithm. Take a moment to orient the audience. Take a moment to orient yourself. E prime is reduced is the most common. All parameters normal left atrial pressure and the indeterminate pathway. (2016) versus 2025 algorithm comparison. Here's the side-by-side 2016-2025. The improvements immediately apparent. What changed? LARS added as a primary supplemental parameter, replacing the less reliable parameters that clouded the 2016 indeterminate pathway. A dedicated atrial fibrillation pathway. The 2016 algorithm had no clear guidance of AF. H-specific ranges. Grading simplify from 4-tier system to 1, 2, 3 indeterminate to a clear 2-grade system with probability links to heart failure with Preserved EF. The net result, fewer indeterminate cases, more clinical actionable results, and direct linkage to heart failure with Preserved EF diagnosis and management. Clinical case 1 of grade 1 diastolic dysfunction. Let's apply the algorithm to a 72-year-old woman with hypertension for 15 years, mild exertional dyspnea. This is the archetypical patients you see in outpatient cardiology every week. Walk through this algorithm. Step 1. Is E reduced? Yes. Average E prime is 5.3, well below the cutoff of 6.5. Therefore, diastolic dysfunction is present. Step 2. Primary variables for left atrial pressure. E to A is 0.67, which is less than 0.8. E prime is reduced, but E to A prime is less than 0.8. E to E prime is 10.4, not elevated. TR is 2.3, which is normal. Pattern: only E prime is reduced, E to A ratio is less than 0.8. This is the classical impaired relaxation pattern. Grade 1 supplemental parameters to confirm. Left atrial reservoir strain 22, which is normal. LAVI 32, which is normal, all consistent with normal left atrial pressure. Diagnosis: grade 1 diastolic dysfunction or impaired relaxation with normal left atrial pressure. Clinical case 2, grade 2 diastolic dysfunction. 65-year-old man, long-standing hypertension with CKD, stage 3 dyspnea on exertion with a trace leg edema, Classic grade 2 presentation. Algorithm. E prime is reduced. Average E prime is 5.5. Therefore, diastolic dysfunction is confirmed. E2 E prime is elevated. Average E2 E prime 16, which is elevated. Primary variable 1 positive. TR elevated 3 meters per second. For all three primary variables, E prime reduced, E2 E prime greater than 14, TR elevated, all abnormal, left atrial pressure is elevated, and the E to A ratio is 1.35. Since it's less than 2, the ratio of E to A, you diagnose grade 2 diastolic dysfunction. Confirming markers: LA reservoir strains less than 16, which leads to elevated left atrial pressure. At this point, we don't need it as well. The LAVI is more than 34. Both are supported. Therefore, the diagnosis is grade 2 diastolic dysfunction, and with mild to moderate elevated left atrial pressure. Heart failure, preserved EF is likely. The management needs to be treated for heart failure with preserved EF. Clinical case 3. Grade 3 diastolic dysfunction. Now we have a 50-year-old woman with dilated cardiomyopathy and EF of 35%. New York heart class 3. Orthopnea. This is the patient who is decompensated and needs aggressive intervention. E prime is severely reduced, average of E prime 3.5, E2 E prime markedly elevated at 41, TR velocity of 3.8, which is elevated, all three primary variables severely abnormal. Therefore, left atrial pressure is markedly elevated. The E to A prime is 3, which is more than 2. Therefore, now we have diastolic dysfunction and elevated left atrial pressure. We can grade 3 since E to A ratio is more than 2. Other confirmatory findings: the left atrial reservoir strain is 8, which is very reduced, and the left atrial volume index is 58, which is markedly enlarged. Therefore, the diagnosis is grade 3 diastolic dysfunction with the restrictive filling physiology, markedly elevated left atrial pressure. Prognosis for these patients is worse than grade 2 diastolic dysfunction. Clinical 4, in indeterminate case that needs supplemental material, as instructed by the new guidelines. A 60-year-old man, hypertension, exertional dyspnea, only prime is abnormal among the primary variables. This is where 2016 would have, say, indeterminate and left you hanging. Let's see how the 2025 handles it. E prime is reduced, septal E prime 5 centimeters is reduced, but the other three variables are within normal limits. E to E prime is 12, TR is 2.5, E to A is 0.28. So now the classic grade 1 pattern with only E prime abnormal and E to A ratio greater than 0.8. We can now call grade 1 diastolic, which requires an E to A ratio less than 0.8. We must go to supplemental parameters. Supplemental parameters described in this case: left atrial reservoir strain of 22 is normal. The pulmonic vein systolic to diastolic ratio is 1.2, which is also normal. A LAVI, left atrial volume index of 30, which is less than 34, which is also normal. In the case IVRT is 95, which is more than 70, which is normal as well. Therefore, all supplemental parameters were normal. At this point, we can deduce that the left atrial pressure is normal. Therefore, this patient has a grade 1 diastolic dysfunction. If this patient remains symptomatic despite normal resting left atrial pressure, exercise stress echo is the next step clinically if needed. Special population. Now we enter in the territory where most echocardiographers make mistakes. The standard algorithm assumes sinus rhythm, no significant valvular disease, no infiltrated disease, normal annular motions in real clinical practice. These assumptions are violated constantly. The 2025 guidelines provide specific dedicated algorithm for each of the following special population. We go through each one, not just the rules, but the physiological why behind each modification. Left atrial estimation in atrial fibrillation. Atrial fibrillation eliminates The A wave, the atrial kick is gone. This means the E to A ratio is meaningless. E to E prime still works, but must be averaged over multiple beats. TR velocity still works, but needs averaging. The dedicated atrial fibrillation algorithm uses four primary parameters. Mitral E velocity greater than 100 centimeters per second. Septal E to A greater than 11. TR velocity greater than 2.8 or pulmonic systolic pressure greater than 35. Deceleration time of less than 160 milliseconds. Decision rule: none or one abnormal. None or one abnormal, at least you can deduce that the patient has a normal left atrial filling pressure. Two abnormal is indeterminate. Check supplemental LAR, pulmonic and BMI as a modifier. 3 to 4 abnormal, you have elevated left atrial pressure. The clinical example on the slide is a 72-year-old with an atrial fibrillation. Velocity 115 centimeters per second, which is greater than 100. Septal E to E prime of 13, which is greater than 11. TR 2.1, which is greater than 2.8. Deceleration time of 145 is less than 160. 3 of the 4 are abnormal, therefore you diagnose as elevated left atrial pressure. Atrial fibrillation algorithm. This is the visual summary coming from the guidelines. This visual shows the atrial fibrillation specific algorithm, and you can commit to memory to determine patients with elevated left atrial pressure or normal left atrial pressure or indeterminate. Now the left atrial pressure estimation with mitral regurgitation. A special case, mitral regurgitation is a trap. The regurgitant volume going backwards into the LA mimics elevated left atrial pressure in multiple ways. It drives up E velocity, blunts S velocity in the pulmonic vein flow, and dilates the left atrium. If you apply the standard algorithm to a patient with severe MR, you'll be frequently overestimating elevated left atrial pressure. One, not to use insignificant mitral regurgitation, E to E prime, or reliable when EF is normal. The E wave is high because mitral regurgitation volume, not left atrial pressure. LARS altered by regurgitant volume. Pulmonary vein systolic to diastolic ratio as wave reduced by MR, not by elevated left atrial pressure. What to use in MR? AR minus A duration greater than 30 milliseconds, which correlates to elevated LVDP. Reliable because the A velocity timing is not affected by regurgitant volume. At IVRT, the ratio to TE prime less than 5.6, elevated left atrial pressure. Clinical example: you have a 62-year-old with a severe primary MR, pulmonary valve AR duration 100 milliseconds, mitral A duration 145. The subtraction of these two values is 35, which is greater than 30 milliseconds, which can correlate with the elevated LVDP and confirm despite normal appearing E to E prime. In severe primary MR, the decision for surgery is often about timing. If AR to E minus A is greater than 30 milliseconds, meaning LVDP is elevated, that's evidence of hemodynamic impact even before EF's decline. This can influence sometimes surgical approach. Hypertrophic cardiomyopathy is a perfect storm for diastolic confusion. The septum is massively hypertrophied. The LVOT grading is elevated. Systolic function may appear hyperdynamic, and yet these patients often have severe elevated filling pressures and disabling dyspnea. The critical pitfall in hypertrophic cardiomyopathy, E to A ratio does not mean necessarily grade 3. In patients with significant LVOT obstruction, the E wave can be elevated because of flow dynamics related to obstruction and hyperdynamic LV function, not necessarily because left atrial pressure is markedly elevated. If you call E to A greater than 2 as a grade 3 in hypertrophic cardiomyopathy, you'll be systematically wrong. Reliable parameters in hypertrophic cardiomyopathy. E to E prime greater than 14, reliable. In this case, 26 confirmed elevated left atrial pressure. TR velocity greater than 2.8. LAVI greater than 34. AR minus A greater than 30. The correct diagnosis in this case presentation of a 45-year-old woman with hypertrophic cardiomyopathy and the findings of the variables measure. The correct diagnosis is a grade 2 diastolic dysfunction with elevated left atrial pressure, not grade 3, despite E to A ratio. Mitral stenosis. Mitral stenosis present the opposite problem from MR. The obstruction at the valve level makes all transmitral velocity artificially high. The velocity of parameters that do work in mitral stenosis. IVRT less than 60, IVRT T or less than 4.2, pulmonary vac systolic diastolic less than 1, mitral air velocity greater than 1.5. A clinical 50-year-old woman with rheumatic mitral stenosis, IVRT of 52, less than 60, IVRT of TE 3.5, which is less than 4.2. Both criteria for elevated left atrial pressure are met. Confirmed left atrial pressure despite uninterpretable E velocity. Mitral annual calcification special algorithm. Mitral annual calcification MAC restrict annular motion mechanically independently of myocardial relaxation. This means E prime velocity is artifactually reduced by the calcium, not by diastolic dysfunction. Using E prime in severe MAC will lead to systemic overgrading of diastolic dysfunction. In the 2025 MAC specifically algorithm shows here E to A less than 0.8 normal left atrial pressure despite low E prime. E to A greater than 1.8 is elevated left atrial pressure. E to A 0.8 to 1.8, check IVRT. If it's greater than 80 milliseconds is normal. If less than 80, elevated left atrial pressure. What not to use in severe MAC? E prime velocity, unreliable MAC, restrict annular motion mechanical. E to E ratio. If E prime is unreliable, E prime derived from is also unreliable. LA reservoir strain also unreliable due to acoustic shadowing from calcium. Restricted cardiomyopathy is the most severe form of diastolic pathology. The ventricle is so stiff that even tiny increasing filling volumes produce dramatic pressure rise. The echo pattern is extreme. And these are the parameters to read on your own. Constricted pericarditis versus restricted cardiomyopathy. One of the great diagnostic dilemmas in cardiology, both present with elevated filling pressure, dyspnea, and edema. Both can have similar mitral inflow patterns, and the distinction matters enormously because constricted pericarditis is surgical curable. Key distinction features tissue Doppler E prime velocity. In constriction, E prime is preserved, myocardium relaxes normally. The problem is external compression. In restriction, E prime is reduced, intrinsic myocardial disease. The single best echo discriminator is E prime velocity. E to E prime greater than 15 reduce E prime points strongly to restriction. E to E prime greater than 15 with preserved E prime myocardial that relaxes normally against a rigid pericardium points strongly to constriction. Sinus tachycardia, challenges and solutions. Sinus tachycardia above approximately 80 to 90 beats per minute causes E to A fusion. The atrial kick occurs before early filling has finished, merging the two waves into a single hump. The mitral Doppler, you can separate E from A. You can calculate E2A. Now, now what? Strategies. Look for the IVRT becomes your best friend. An IVRT less than 70 meters per second has a 70-year specific for elevated left atrial pressure without E2A ratio. If truly indeterminate, rate control the patient medically, beta blocker, diltiazem, and repeat the study once the heart rate is less than 80. This should be standard practice when tachycardia significantly limits diastolic assessment. For ICU patients with persistent sinus tachycardia and clinical concerns for elevated filling pressure, LA reservoir strain and pulmonary vein systolic diastolic are your most reliable tools. LARS particularly doesn't require a good mitral flow signals and can be measured even in tachycardia. Pulmonary hypertension is not a single disease, it's a syndrome with multiple causes. The echocardiographic distinction between group 1, precapillary primary pulmonary hypertension, and group 2, postcapillary drives by elevated left atrial pressure has major therapeutic implications. Heart transplant are physiologically unique. They denervate. They may come from young donors with very compliant ventricles, and early restricted physiology can be normal in the first weeks after transplant. In transplant surveillance, the focus shifts from absolute value to trend. An E2E prime that was A 6 months ago and now is 14, even if it's still within normal limits, is clinically significant and warrants further evaluation for ejection or allograft vasculopathy. Exercise echocardiography indications and protocol. Exercise echo is the bridge between a normal resting echo and the clinical reality that many heart failure with preserved EF patients look completely normal at rest. Their diastolic reserve is exhausted only when demand exceeds capacity during exercise. Indication for exercise echo: a grade 1 diastolic dysfunction with unexplained dyspnea on exertion, a normal resting left atrial pressure with symptoms disproportionate to clinical picture, indeterminate diastolic function with functional limitations. When not to do exercise echo: already elevated left atrial pressure at rest. You have your answer. Normal E prime without any diastolic abnormality. Low pretest probability. Severe valvular disease. Symptoms are explained by the valve protocol. Supine bicycle preferred. Allows continuous imaging during exercise. Bruise or modified bruise protocol to symptom limitations or 85% maximum predicted heart rate. Measure E prime, E to E prime and TR at rest and at peak exercise. On treadmill, acquire images within 60 seconds of stopping. Diastolic exercise interpretation. The 2025 criteria for a positive exercise echo for elevated left atrial pressure are specific. Both E to E prime greater than 14 and TR greater than 3.2 at peak exercise. Both criteria must be met. Interpretation framework. Elevated left atrial pressure, average E to E prime greater than 14 and TR greater than 3.2 is positive for heart failure with preserved EF. Normal left atrial pressure, E to E prime less than 10 and TR less than 2.8, heart failure with preserved EF is unlikely. Consider alternative diagnosis. Indeterminate E to E prime greater than 14, but the TR only 2.8 to 3.2. Consider right heart catheterization with exercise. Clinical examples. The slide 64 VO women with grade 1 diastolic dysfunction, exertional dyspnea. At rest, E to E prime normal, TR 2.4 normal as well. Therefore, normal left atrial pressure. At peak exercise, E to E prime elevated, TR is 3.6 elevated. Both criteria are met. Diagnosis: positive for exercise-induced left atrial pressure elevation, unlikely heart failure with preserved EF. Clinical physiology observation: normal E prime increases by 3 to 5 during exercise as catecholamines enhance myocardial relaxation. In this patient, E prime barely moved 5.5 to 6. Lack of diastolic reserve. The myocardium cannot accelerate its relaxation in response to the increased demand of exercise. This is pathophysiological signature of heart failure with preserved EF. Clinical case exercise echo. In this case, drives home the entire lecture. A 50-year-old woman with obesity, BMI, exertional dyspnea. At rest, she looks fine. Grade 1 diastolic dysfunction on most. Her left atrial reservoir strain is 20, borderline but technically normal. You might be tempted to reassure her. Exercise stress echo tells a very different story. E velocity of 158, more than double from rest. E prime at peak 7, barely moved from 6.5, no diastolic reserve. E2 prime at peak 23, well above the 14 threshold. TR peak velocity 3.8, well above the 3.2 threshold. Both criteria are met, therefore this is a positive for exercise-induced left atrial pressure elevation. Diagnosis of heart failure with preserved EF. Symptoms: exercise-induced elevated feeding pressure. Heart failure with preserved EF diagnosis. The HFpEF score is validated clinical scoring system developed at the Mayo Clinic for estimating heart failure with preserved EF. Probability before proceeding to invasive advanced imaging is straightforward to calculate in clinic. 6 variables, 6 clinical risk factors. They are delineated here. Depending on the score, probability of having heart failure is determined. Heart failure with preserved EF diagnosis. The heart failure HFpEF algorithm in the European counterpart to H2FPF developed by the Heart Failure Association of European or ESC is more comprehensive, incorporating echo, biomarkers, and functional parameters in a stepwise approach. This is heart failure with preserved EF diagnostic approach, step by step. This is the integrated clinical pathway for heart failure preserved EF diagnosis from the encounter to confirmation diagnosis of the new guidelines. Step 1, clinical assessment, history, exam, natriuretic peptides, EKG, check success rate. Step 2, comprehensive echo, exclude a structural alternative, significant valvular coronary disease, LV dysfunction, amyloidosis, hypertrophic cardiomyopathy, and constriction. Apply the 2025 diastolic algorithm, grade diastolic dysfunction and estimate left atrial pressure. Assess LVEF must be greater than 50% for heart failure with preserved EF. Decision tree after echo. Left atrial pressure is elevated at rest, plus normal EF, plus symptoms, heart failure with preserved EF confirmed. Normal diastolic dysfunction, normal diastolic, normal left atrial pressure, non-cardiac dyspnea, investigated lungs, deconditioning anemia, normal left atrial pressure at rest, but symptomatic exercise echo or right heart cath. Heart failure with preserved EF diagnostic criteria. The must have for symptoms plus LVEF greater than 50% plus elevated left atrial pressure, rest or exercise plus exclusion of alternative diagnosis. This is the complete decision tree for heart failure preserved EF diagnosis from the 2025 guidelines. Future directions in diastolic dysfunction assessment. The field is moving fastly. AI and machine learning might be the future. 3D echocardiography and cardiac MRI may also contribute, as well as technology improvement. Key takeaways. Let me close with the 6 points I want you to walk away from here today. The 2024 guidelines add the left atrial reservoir strain less or equal to 18 as a key supplemental parameter and provides an age-specific reference range. The two-steps approach assess E prime. First is relaxation impaired, then check LV remodel markers. Is left atrial pressure elevated? Diagnosis of diastolic dysfunction and grading diastolic dysfunction are separate questions. Left atrial pressure estimation uses three primary variables: E prime, E2, E prime, and TR. All three are normal, elevated left atrial pressure. All three normal, left atrial pressure is normal. Mixed, check supplemental. A special population needs special algorithm. AF, MR, hypertrophic cardiomyopathy, MAC, transplant. Each has a specific modification. Applying the specific algorithm in this patient leads to systemic errors. Exercise echocardiography is essential for diagnosis of heart failure with preserved EF in symptomatic patients with normal and resting left atrial pressure. A positive criteria: E to E prime greater than 14, TR is greater than 3.2, a peak exercise. Both require the multi-parametric approach with clinical context provides best accuracy. No single parameter makes diagnosis. Grade the patient, not the number. Thank you very much for your attention.